Dr. Chiu wearing one of his many hats and talk about quality improvement.
So I haven't had the pleasure of meeting the whole group, other than Jesse, who I happen to have known for a little while. Would you mind just introducing yourself? If you could just tell me where you're from.
I can start. I'm Robin. I'm from U of M.
Welcome, Robin.
I'm Lexa. I'm from U of A. Suzanne, done hygiene Halifax.
Welcome.
Duncan, I went to school in Ireland.
Awesome. Which school in Ireland?
Trinity.
Trinity, that's a great school, yeah.
I'm James, I'm from here.
I'm Karen. I'm from Toronto.
I'm Flora. I'm also from Toronto.
I'm Henry from Sudbury.
I'm Linda from U of A.
I'm Jonathan, I trained in Toronto.
So, I've known Jesse since the first year, I guess. It's been a while. So my name's Aaron. I'm a neonatologist. I trained in Toronto, so I'm a U of T grad. And then I did a rotating internship at Northridge General in Toronto before I did my pediatrics at Chiu. After I did my pediatrics, I did my neonatology in Chiu as well. And I was working on a ClinEpi Masters at Chiu while I was doing my neonatology fellowship at that point in time. My career is as adverse, or not adverse, as awkward, as bizarre as you can imagine. Although I was hired here as a clinician scientist, and I used to do a lot of, I started off basic science research, but I do a lot of clinical research, mostly clinical trials and database research relating to neonatal care. My expertise tended to be methodology in terms of how to do things. And one of the biggest things I did was an international randomized clinical trial as it relates to non-invasive ventilation in newborn. What I ended up gearing towards is much more within education, and then also within quality or business practices applied to medicine. So I'm an MBA. You might have known that I was a program director for your program quite a few years ago. I was seconded to, while I was program director for neonatology, to look after this program and to get us back to where we need to be. And then after having done that, they told me, or I graciously asked for, or I begged and pleaded for time off to reset. And I thought one of the things that I noticed while I was a program director and in the neonatology was the way we administer things, the way we do things, just didn't seem to make a lot of sense. And thinking that business practices are much better at how to administer, and perhaps I can learn quite a bit by doing an MBA. So it was very selfish for me to go and do the MBA. There was no purpose to it other than I got out from doing clinical medicine for a year and I didn't have to be in the hospital thinking about call schedules and everything. But to my surprise, I really loved it. It's been fantastic. So my MBA was focused on decision-making and organizational behavior or change management with it. And that was I'm going to get that wrong. I think it's 2012 now that I did the MBA, and I've been very surprised in terms of where that's gone. Part of it is quality, business practices, risk management with it. The other part is productions and lean management. So I run a public health program that uses lean methodology. The other part of that is financial management. I know how to look after a spreadsheet pretty darn good in terms of fiscal resources. So I sit on the board of Doctors Manitoba, and I sit on the board of MD Financial because of my business background and my money management background. So it's been actually quite a bit of surprise what has happened. I also work at the Dean's office, and at the Dean's office I'm work on quality improvement as it relates to education and accreditation, which is really just meeting standards with it. So I'm going to talk to you about quality improvement as it applies to medicine. It can be a really dull topic, and in some days it is a really dull topic when we're talking about, do we meet our metrics? Are we hitting our scorecard, balanced scorecard? What's the outcome? But really the perspective here is benchmarking and risk management. What we do is fantastic. I imagine you guys are loving being a resident right now. I hope you are. There was a general silence. I'm going, what did we sign up for?
I think that they didn't like the rest.
Okay. It's just that you get to do so much. The problem becomes, because we get to do so much, there's errors in the system. And errors tend to amplify. And when errors amplify, we have patient harm. And what we try to do is recognize that errors exist in the system and to try to create a system that is going to minimize error or allow us to find those errors and try to mitigate them. Your ask rotation objectives is to develop tools to be used daily as clinician and clinician scientists. We want you to have the ability to ask questions and addressing those questions using a variety of academic tools. I want to talk with you about a different set of tools beyond clinical trials, beyond clinical studies. The objectives for my talk are really brief. I want you to recognize the importance of quality improvement, identify the 6 dimensions of high quality health care, a STEEP concept, recognizing that system issues can affect quality of care, and a lot of what we do in quality improvement is looking at the system, not necessarily at the individual, but at the system. What happened in the system that ended up making you create this decision that had this adverse outcome? We want you to compare the differences between clinical research to quality improvement, and then name the steps in the IHI model for health improvement. And I want to discuss 2 brief quality concepts, and that's a Deming cycle, the PDSA cycle, and the lean methodology, or lean concept. So really, this is my life. This is what has happened to me. The concept is that I wanted to be the best clinician I could. I like to think I'm a pretty good neonatologist. Nobody's fired me yet, so maybe I'm doing good. But then to be a good clinician and you want to have better impact in terms of quality of care, I can't be on service 24/7. But if I'm a better teacher, I can teach students, residents, and fellows how to be a good neonatologist, how to work well in the NICU. Well, I can teach one person, but if I end up creating a good program, then I can teach more individuals in that program to be good clinicians, impacting the patient care. Then if you work at the Royal College level, I was a Royal College chair for my specialty, if I create the right standards to do this, then you can have a good level of national expectations, what you want to be as a neonatologist. The last bit, though, is no matter how good you are, it's the infrastructure. It's the system that surrounds you that has the biggest impact. So if you really want to make substantive changes, it's going to be the infrastructure, and that's what we're trying to tackle. So why quality and patient safety? Well, ever since, I just find it funny, it's, 3 months and colds and flus? This is prime time, right? Welcome to pediatrics. In 1999, the Institute of Medicine started saying that we have a problem here. Over 40,000 to 80,000 Americans die yearly because of medical errors. Not because of their underlying condition, because of medical errors. In 2001, the CDC said, if we look at hospital-associated infections, infections you acquire not because you came into the hospital with it, but because you developed it in the hospital, about 700,000 hospital-acquired infections happen in the acute care center in the hospitals. This doesn't even talk about the general wards. This is an acute care setting. And of those, over 75% die because of their hospital-acquired infections. Okay, you might think this is all right, it's the ICU, but over 50% of those cases happened outside of the ICU. This is not the sickest of individuals. This is somebody who came in for one reason or another, developed an infection, and it was that infection that killed that individual in the hospital. More recently, in 2013, a group called Leapfrog looked at the outcomes in terms of the, in the US, and they identified that there was over 400,000 Americans died yearly from preventable hospital errors, accounting for the number 3 cause of death in the USA. Unbelievable. Not because of the underlying disease, but because of hospital error. Okay, we're not talking about individual error, we're talking about hospital error. Okay. How many of you flew in the past 6 months? How many of you flew and expected that you might die because you boarded an airplane because it's the third number of times you did? You thought about it? Okay. I think we need to refer you to services. You never think about that, right? Because that industry is really well designed to prevent adverse redundancies upon redundancies, thinking about systematic issues. But it's gotten to the point where in healthcare, we are starting to accept that that is the cost of doing business. Every once in a while, mistakes happen. That's true. But number 3? Don't you think that's a little bit high? Okay. The other thing that's coincided with all of this is the whole concept that healthcare cost is not going down. So we might be having more bad outcomes because we're spending less money. No, that's not true. We're having worse outcomes because we're spending even more money. So whatever we're spending on doesn't seem to improve the patient healthcare outcome. I go back to the Royal College. You've seen all of this, right? This is what you're mandated to learn with regards to the medical expert. And what I've listed here is all the criteria within the CAMMED's rules related to pediatrics that talks about quality. Every single thing that's there, other than collaborator, specifically talks about patient safety and patient quality. Royal College is taking this very seriously. This is a mandatory part of your learning because we are concerned. So I have a simple goal when I approach the patient quality issues. I want to produce or create or develop or deliver effective therapy, but I want to do it with the minimum risks possible and the lowest cost. So whenever I'm working, those are the 3 things I want to think of. First of all, the best treatment that's possible. But those treatments that are possible that has the lowest amount of risk. And if I can do it, the lowest amount of cost. Okay. By the way, I'll send you a copy of the deck afterwards. So people talk about if it's a system issue that's there, what is a high quality healthcare system? And they talk about a STEEP, S-T-E-E-E-P, which talks about safe, a system that avoids injuries, timely, which reduces wait and harmful delay, effective, meaning that it's based on scientific knowledge, providing an appropriate level of care, and efficient, which is avoiding waste of equipment, supplies, ideas, and energy. Equitable, meaning that you do not vary in quality because of personal characteristics. And you might be surprised that that is something that we are still working on this day and age, even here. And if you heard about the Sinclair inquest, it is endemic. And patient-centered, meaning that we are respectful of and responsive to individual patients. That's fairly straightforward, right? A fairly good ideal. Okay, when we talk about then high quality healthcare system, we are really talking about what is the problem with the system. And the concept in quality improvement is that it is the system that's driving the outcome. Every system is perfectly designed to get the results it gets. And within healthcare, most of the problems in health and healthcare are not due to mistakes that are made by uninformed or lazy people, but rather they can trace all the way back to the problems with the system in which they have to work. How many of you bought a house or a condo when you moved here?
We're all renting.
Wow, that's great. Why are you renting?
I have a house in Halifax, so. I did not need that. Because a lot of investment.
It's a lot of money to go into it, right? Were you worried that you're buying at the high time, that it is overpriced at this point?
Not so much as I couldn't afford it.
Yeah, I just don't have money.
Well, that's
Talking
fair.
about borrowing for down payment.
Yeah, part of it was just like coming here and not really knowing where to buy or like what I really wanted, but we are like considering buying.
You are considering buying it, okay. So, right now, interest rates are low. Interest rates are low, meaning that there is an incentive to borrow. It's not a disincentive. Money is cheap. And if money is cheap, tendency is that, why don't I borrow? Because it doesn't cost me that much. I make a certain amount of money, the cost of managing that loan isn't very outrageous. That makes sense, doesn't it? Well, you're not the only one that's doing it or thinking about it. And because you're not the only one thinking about it, that's why house prices are going up and up and up. Because more and more people are going into the market thinking, I can afford a house because the cost of the loan, managing my debt, is not that outrageous. The system, in this case, the inflationary policies for the low interest rates, is creating the outcome. In this case, people going into the market. Same concept as it regards to the stock market. The stock market has gone really, really, really high, in part because people want to make money with their money. If they put it in a government bond, you're not making a lot of money. So they want to put it in something that earns a bit more. And one area they can do this is the stock market. And some people like borrowing money to invest. It's only cost about 2% to borrow money, but if I can go to the stock market and I can make 5%, I have a spread of earning of 3%. So that's another reason why the stock market might have been going up and up and up. So the system of low interest rates, it's getting exactly the outcome that we expected. What's the problem with that?
Or overstretching themselves.
So all of a sudden, the system has a low interest rate, but the system eventually will want to have a high interest rate. Can you adapt to a high interest rate?
Some people can.
Some people can. So I lived through an era when interest rate was hitting 20%. Can you imagine that?
It's like buying a house on a credit card.
20%, yeah, and I'll get to that in a second, that's a really good
My
idea.
mom told me they bought their first house like in the 80s when interest was like 28%, and she's like, it was ridiculous.
It was painful, painful. You know who really did well?
People would say,
People in the market, yeah.
People who had savings and they put the money in interest-bearing bonds at 20%, and then as the interest rates went down to about 5, 6, 7%, they really did well. Okay, so the system drives the outcome, forces you to do what a natural thing to do. Sometimes it works great, but sometimes the system makes you to make a serious error. Okay, this is a bit of an aside though. I'm talking about in terms of a credit card with 28%. How many of you have student loans? Good for you. Good for you. You needed student loans to go through. And student loans is a very reasonable way to try to use money when you go through, because you didn't have to pay anything at this point in time, right? What if I tell you that the student loan is a credit card? And with a credit card, you have to pay monthly installments, pay it off, or you accrue interest. If you don't pay it off, you collect interest ongoing all the time. Would that have changed the way you use your student loan? No.
Student loan didn't cover.
And the way I use a credit card is, like, I don't leave anything on my credit. Like, I use a credit card differently than a student loan by nature, but I couldn't afford to make a choice. Like, they're different to me.
They're different in terms of how you use it.
Yeah.
But if I, instead of call it a student loan, I call it a student credit card, the only difference between a student loan and a student credit card is, student loan and a credit card, is that the student loan, you don't have to pay off the debt at the end of every month. You have to start paying off the debt at the end of your training. That is the only difference. By calling it a student loan with an open-ended payment, it sounds sexy. It sounds different than what it is for a credit card, but it is a credit card, a low-interest credit card. But when I start calling this, instead of a student loan, a credit card, your thinking is different. because you know that I have to pay this off, otherwise I have to start paying off interest. Well, that's what your student loan is doing. You just don't have to pay it off every month. They'll still let you put money on there. So the system, credit card versus student loans, has created a way that you treat them differently, even though in general they are the same thing. Okay. So let me talk a bit about what system issues there are there. Well, in the 1940s, the number one cause of blindness was being admitted to the NICU. What happened was people realized that this was before the days of ventilation, before the days of surfactant. If I give at-risk babies at the edge of viability, which at that time is probably somewhere around 32 to 34 weeks gestation, oxygen, I can make them breathe better and they look better and they survive. A little bit of oxygen is good, but if I can give them more oxygen, all the better. So they can purify the oxygen, and the incubator became much more closed environment. So I can now give 25, 40, 100% oxygen. What they didn't realize was giving unrestricted oxygen affected your eyes. So the number one reason why the people went blind was because of the use of oxygen in ICU. Great concept, we kept the baby alive, and it took them over a decade before they realized what was going on. To the point where some of the granddaddies in neonatology, this was before you even called neonatologies, could never reconcile the fact that they caused a whole generation of blind infants, and they left neonatology. And one of them actually went to work for the Blind Institute to atone for everything that they've done. Okay. The other thing, more recently, is that the outcome of extreme prematurity, we know is related to the gestational age, right? The younger you are, the more difficult you are. The more problems you run into, the worse your outcome that you have. But there's variations in outcome between hospital and hospital, country to country. Why is that? Because there's difference in terms of decision that we do. Difference in terms of the way we set things up. Difference in terms of decisions that we made, both in benefit, but also in decreasing complications and harm. Every clinical decision I make in the NICU, especially when I'm doing at the edge of viability, comes with the positive, but comes with a negative. And what you do is you choose those that have the highest chance of positive with the lowest risk of negative. And if you can't choose something like this, you mitigate the downside effect, meaning you try to do everything to decrease harm if you have to choose a clinical outcome. How many of you have seen oscillator ventilation, high frequency oscillation? Yeah. Do you know what happened with the largest clinical trial that they start doing this in preterm infants to try to treat for RDS? You know what the outcome was? Who died? Babies who went onto the oscillator compared to conventional ventilation. The first high-frequency ventilation randomized clinical trial showed that babies who went to high-frequency oscillation had a higher risk of death and intracranial hemorrhage. It was a great concept, and it still is. We use it all the time, but they were using it wrong. They didn't know they were doing it wrong. It just made sense. And the reason they did it wrong was they used low PEEP or zero PEEP, where now we know you have to have some form of vent expiratory volume to keep the lung open and oscillate above that. What they did was oscillate to generate opening pressures and closing pressures with it. And when you do that, you transmit that to the brain. So you had a higher incidence of death related to this. Okay, the Cochrane Library, you guys probably seen this all the time. What does that logo mean? What does that logo mean? What does this logo mean? So this is a tree, a meta-analysis with a tree, forest plot, with individual randomized clinical trials. And this is the summative assessment of all that, showing that in this case there's a benefit, reduction in harm. Do you know what meta-analysis this is from? Because there's a reason why it's this. It is a meta-analysis, and it became the Cochrane because originally it was the Oxford database. And this is a meta-analysis for antenatal steroids to prevent neonatal outcome or complications of neonatal outcome. The reason this puts up here is that we've known since the 1970s that giving mom antenatal steroids improved newborn outcome. Decreased chance of RDS, decreased death, decreased intraventricular hemorrhage. We've known that. And have we done a meta-analysis at that time in the late 1970s, it would have been conclusive that we should be doing it. Do you know when it became standard to use antenatal steroids in preterm infants in the US? 90s. Yeah, 90s. It took 20 years before we realized it was good because people were doing clinical study after clinical study after clinical study. So the Cochrane logo reminds us if we have data, we should be looking at that data to ensure that we've already found the answer instead of keep doing ongoing studies after ongoing studies. And they talked, somebody actually looked at the number of patients that had to go to clinical trials who was in the placebo arm receiving substandard care when we knew already that this was beneficial was not an insubstantial number. Scary, isn't it? So personal experiences in terms of how the system ends up having bad outcome. Well, we've had surfactant given intravenously instead of intratracheal tube. How in the world can that happen? You're busy doing the resuscitation, 2 vials of medications are at the bedside, unlabeled, somebody's using it for a flush, and all of a sudden surfactant goes through the IV instead of endotracheal tube. Horrible, isn't it?
What happened?
Funny thing is, those are the original clinical trials. They thought surfactant should be given IV. So the original clinical trials used to give surfactant through the intravenous. It doesn't work. It doesn't work. And it is not necessarily sterile, but it wasn't as harmful as we thought. But you joke about it, but you're sitting there going, in the mad rush, I'm trying to flush the IV and instead I'm giving surfactant. How in the world could we do this? It's because the system. People were rushing, unlabeled, trying to get too much done too quickly, undocumented, ended up with this. We used to do well, when we intubate, I don't use a stylet, but some people use a stylet to do intubation. One step that we had was when we put the endotracheal tube in, we have to remove the catheter to put on a special adapter that allowed us to suction. It was a built-in catheter. It used to be that catheter had to go onto the plastic part of the endotracheal tube. You could not use the hub that came in with the endotracheal tube, so you have to remove that hub, put in this catheter that had an inline suction for you to use it. So it was an added step after you put the tube in, you had to remove that hub, put the new hub in so you can suction with it. They thought, why don't we get rid of that, do it all one step? Well, create tubes that already had a built-in catheter that's in there and sterilize the system so I don't have to unplug and cause a problem. Problem becomes the hub now has a V because one is ventilation, the other one's suction, so when I put a stylet in, it's a bit of a snug fit. You can fit it in, but it's a bit of a snug fit. And people tended to use a stylet on these endotracheal tubes because once you re-sterilize them, they're really soft. So they lose a natural curve and you have to do this. Well, 2 times intubated with stylet. Stylet didn't want to come out very easily. Pulled. We're ventilating okay. We take an x-ray and we see the endotracheal tube in there, but there's something plastic protruding from the endotracheal tube. What the hell is that? Look at the stylet. The stylet is a piece of metal with a plastic covering it. That sheath got removed when you pulled it out, and that sheath was actually still in the trachea. And what we're seeing was it in the trachea. All right, 1 time is enough, right? 1 time it's probably just bad luck. Happened to us twice before we realize this is not working. We've created a system that is now causing problems. We were lucky. Both times we were able to remove it without actually having to go to the OR, but it could have been worse, that it could have been aspirated into the lung, and I had to go with fiber optic to try to get rid of it. Okay. Other examples include in adults, cesarean section that's poorly planned because the baby's too big, and people use a Fensteel incision, head wouldn't come out, people panic and start making a T incision. Well, when that happens, you can't ever deliver vaginally again. In adult ER, one of the most commonly missed MIs is a posterior MI. It's not an easy one to find. Or in NICU, baby's being resuscitated, you put a UVC as a central line for resuscitation. You don't have to put it in the right place. It just needs to get blood back. But if the baby's covered, you don't see where it is, and it may not be sutured in properly. We had a transport where people didn't realize that this was not secured well, and in the midst of transport, the umbilical line came out, and the baby exsanguinated from the umbilical vein because there was nothing stopping the bleeding. The baby was in DIC for other reasons, and the blood came out. Massive transfusion, and unfortunately bad outcome. And then although you don't see it often anymore, historically we had PDA ligations. We, as in not in this center, internationally, not us, but it happens. People do a PDA ligation, and the PDA and the descending aorta looks the same, and it is really easy to clip the wrong thing. Do you think these people did this willy-nilly? That they went ahead and do this bad things? No, it's because the system ended up allowing them to do that. So what's the difference between quality improvement and research? Well, the question is the same. We have background, we have design, we have measures, analysis, and we apply back to the same original question. So the process remains the same. We use the same PICO format. But beyond that, things differ. Whereas in clinical study, we aim for large sample size, one large test with change in only one or very few variables. We randomize to ensure there's no bias. We blind the assessment to ensure there's no bias. And we have a large data collection so we can look at all the different variables that are there with the aim of proving effectiveness. In quality improvement, the purpose is doing it in a short focus. So small sample size, even as small as one patient. Rapid sequence test, changing multiple variables to try to get an outcome that's better. I don't need to randomize as much as to choose a representative sample, and it doesn't have to be blinded. It should be unblinded. People should know what we are doing. And instead of collecting large data set, we should just collect enough to make sure what we're doing makes sense. And on top of that, the focus is sustained improvement. Not just end of the study, but this leads to the next thing to have sustained improvement. So the big methodologies within quality improvement are a couple, and these all come from business. How many of you drive a Toyota? Why do you drive a Toyota? Or a Honda? How many of you drive a Honda? Okay. Why do you drive a Honda or a Toyota? It's probably cheaper.
Cheap and great vehicles. Never break.
They never break.
No.
So, and the reason why they never break is the Japanese worked very hard on quality improvement after World War II. Their whole concept was, we can't beat on style, but we can really beat in terms of quality. And they've done a really good job until recently based on quality. And they do quality using these sort of manufacturing quality improvement techniques. The PDSA cycle, and I'll go through this in a little bit. The lean methodology, Six Sigma, system engineering or system dynamics, and something that's called an Ishikawa or a fishbone diagram. And you're probably most familiar with the fishbone diagram, which is the root cause analysis, tracing back in terms of what's going on to try to figure out what works or what caused the situation. Okay. The last little bit before we go on to the marshmallow challenge is what's called the model for healthcare improvement. So normally what we do is we follow this setup. We set a name, what are we trying to accomplish? And I'll give you an example of one that we're working on. We're trying to improve outcomes as it relates to newborns who have neonatal abstinence syndrome. And we want to improve outcomes in the sense that too much variability, too much rebound, delayed discharge because of rebound. So we want to establish and measure. What do we want to measure? Outcomes, processes, or maybe a combination of both of them. And in our case, in terms of neonatal abstinence, we want to measure rebound effects and length of hospitalization. Then we identify what we need to change. And what we identified was there was too much variability in the weaning of patients with neonatal abstinence syndrome. Some wean much quicker than others. Others wean different medication or combination, and that variability might be causing rebound and causing poor outcome. So we test the change. We tried doing this way. We measured the outcome and seeing whether that way worked better with 1 or 2 patients. If that didn't work for the next patient, we worked trying to do that, do the other ones. So we plan, do, change, assess. And then with that, we came up with the protocol of what seems to work best that people would agree with. And now we're implementing that change as a system-driven change in the intermediate care nursery. Okay, make sense? Good. Now we go to the marshmallow challenge. Have you ever done, anybody ever done the marshmallow challenge? You know of it? Okay, but nobody's done it? My only request is please do not eat the marshmallow. I'm a little bit ashamed, but these are the same marshmallows I used last year. So they may smell good, but I can't trust on the quality of those. I'm gonna ask you to have teams of 3 or 4. There's gonna be 3 teams. Your objective is to build the tallest freestanding structure that supports your entire marshmallow, your one marshmallow. So do you get this? The tallest freestanding structure wins. Whoever creates a freestanding structure that has the tallest marshmallow wins. Make sense? The tools that you are given is that you have 15 minutes to do this. You have a certain number of equipment. Each team will be provided with 20 sticks of spaghetti. So your final structure can have no more than 20 sticks of spaghetti. If you break it, you can always get more, but no more than 20. You can keep the marshmallows together by tape. Ooh, sorry, I only brought 1 roll of tape. By string. And you're only allowed to have 1 marshmallow. So you can't use marshmallows in any of the structures. No, you have to, it has to be whole marshmallow. It has to be a whole marshmallow. Okay. Any questions? So you're going to be provided.
Does the marshmallow sit at the top of the structure?
You do whatever you want, but the team that wins is the one that has the marshmallow that's at the highest. With the marshmallow on top.
Because the marshmallow could be in the middle and then the structure.
Sure, you could if you want to do that, but it's wherever the marshmallow is, wherever the marshmallow is, that is. So you can have an apparatus this tall, but your marshmallow is here. Your marshmallow is measured there. Any questions?
Do we need to move said structure? I can stay in.
You can stay wherever, but it has to be on the ground. It has to be on the ground. For me to measure, it has to be on the ground. Okay, so there's 11 of you. I'm going to suggest 2 teams of 4 and 1 team of 3. Does that work well? So this group, and then this group? Is that okay?
Yeah.
If you want to put it on the table, it's okay, but you probably want to put it on the floor. It's probably more safe. You're provided with 15 minutes. Come and get your equipment. And my apologies, I meant to get more tape, but I guess you're just going to have to share the tape if that's possible. Yeah, and remember, please do not eat the marshmallow.
Can we get some extra spaghetti just in case we break stuff?
No, you can only take 20 at a time, and if you break it, you can come back and get one. So can I suggest that you peel off as much tape as you can?
I also have some clear tape.
Oh, great, thank you, please, thank you.
It's not my tape, but it's the box.
You can take the whole bunch of string, by the way. There's scissors for everybody. Take the whole bunch of string, there's scissors for everybody. Everybody got a marshmallow?
I just want to take that because they have the tape. I have
There's some on the tape there.
You get the string itself.
Okay, everybody has a marshmallow? Yeah.
Sorry.
Let's just think about there's part of it. Whenever you have to do, that's why I found it.
It's a big piece from, do like square base. Or you can use pillars.
We can really
Does it have to be 20?
I think we can use it.
Anything up to 20. You don't have to use 20.
But no, like for 20, do they have to be intact or can we break them in half?
You do whatever